Okay.
Yes, mostly with the aim.
Can you hear me?
I actually link circulating biomarkers.
Okay, I just need a confirmation that you can hear me, and then we start.
Sensitively and specifically new bleeding in previously stable lesions.
Okay, so welcome everybody. We start this third episode of this webinar. Is about the anatomy, the webinar of WFNS. We organized this with Sebastian Froelich and Carolina Benjamin and the colleagues. We are at the third episode, and today we will talk about the anatomy of the internal carotid artery. We will have some speaker. Me, I will start with the anatomy and classification. Then I'm happy to introduce Andrea Bartolo, that is a neuroradiologist from my department, that will talk about the radiological anatomy of ICA. Then we will have Carolina Benjamin. She will talk about the delicate topic, the anatomical landmarks for the ICA and the rupture, the management of rupture in case of rupture for the extended endonasal approaches. And then we will have Sebastian Froelich talking about the exposure of the ICA during transcranial open approaches, and interventional neuroradiologue from his department will talk about the ICA balloon test occlusion. So I start to share my presentation. Do you see my slide? Okay.
Work on change
put it on full
change
screen
over time.
Okay, so my work in this department in Italy is called Neuromed in central south of Italy, small town, but very big department. These are my conflict of interest. So we have a nice lab, and also dissection that you will see in the presentation are coming from our lab, from the hard work done by the fellows during the last weeks for this presentation. I start with carotid classification. Many different classification have been proposed among the years. The first one actually was proposed by Fisher in 1938. This classification has been used for many years to localize the intracranial mass lesions in the area where the MRI and CT scan were not available, but some problems were evident here with this classification because the nomenclature, the names went against the functional. And the extracranial ICA was excluded. That was not very useful to describe the ICA. So in 1981, we had a second classification, action of the flow, entire ICA, private, except the finance. Another classification comes out in the 80s. So much. This published very smart classification that pages.
Excuse me, Paolo, I can't hear you well.
Okay. Hold on. I don't know what can I do.
I don't know if it's only my problem or not.
Mine metabolites
No,
and
can't hear you
proteins
as well.
will be
No. Hold on. Can you hear me now?
Yes, sir, we can hear you.
Yes, I can hear you.
Better? Better than before?
Yeah, better than before.
Okay, perfect. So I have to start back. Okay, can you hear me well now?
plausible
Yes.
mechanistic
Can you hear me well now?
iron and permeability with near perfect sensitivity and specificity.
Okay, so let's start again from the carotid classification. I think now you can hear me much better. So as I was trying to tell, the first classification is from Fisher in 1938 and was used to localize the intracranial mass lesions, the tumors, because in that area, obviously the MRI was not available. But this classification had some problems because the numbers of the ICA went in the opposite direction of the blood flow, and the extracranial ICA was not included, and also the specifications were not useful to describe the ICA. So second classification came out 1981, was much more complete, describing the direction of the flow of many segments of the carotid, except the clinoid segment and the Petrous segment. So another classification came out in the 80s, which was much more complete, but the IC segments were based only about nowadays without the And characteristic of this classification
We lost you again.
is that the characteristic of this classification is that um, they propose 7 segments, so a complete. They included the complete ICA from the cervical to the Petrous, Lacerum, Cavernous, Clinoidal, Ophthalmic, and the communicating segments. The classification is in the direction of the flow, of the blood flow, and segments are very useful to describe the intracranial aneurysms. So the characteristics is on the arteriography, on the angiography will be described later. So let's see the anatomy of the carotid. In this beautiful picture, you can see the whole intracranial carotid artery, and you can see immediately that to see the whole intracranial carotid artery, you need to cut the nerves, to remove the nerves in the cadaver, and open all the bony corridor inside. This why? Because the carotid, this is a right side. The carotid has a all the segments, nervous system, all the and bony structures. Fetus and sphenoid. See this section, see carotid center, all the corridor, and moving the use so we will use the classification of to describe the segments. You will see the section and images from different colors. It is useful to see the variation. So the first segment is the cervical segment of the ICA. Begins where at the end of the bifurcation of common artery, more or less.
Second indication, so more commonly you have more than one
Paolo,
lesion
it's
in
breaking up.
lesions.
Cervical C4 cervical vertebra, and you can see the relationship between external. The carotid artery runs inside the carotid sheath and is medial to the jugular vein and anteromedial to it ends up in the entry point of the if no branches, the internal ICA at this level in the cervical point. Just to give a brief branches of the external carotid artery that can be related sometimes with the surgery or can feed some meningitis. So you can see the external branches artery. Here is a zoom of the superior artery. Then the lingual artery. This is here you can see the relationship. Internal carotid artery in the carotid sheath with the internal tube. Then we go on artery, you see all the branches of the external artery, the occipital artery here. Here has been attached to show the nerves in the conduct in the colon. And then another important branches that can be related to tumor, hospitalization, skull base thrombosis. So let's go to talk about in the intracranial portion. Petrous ICA. The Petrous ICA starts and runs inside the carotid canal through the Petrous bone. Now is divided into 3 segments: vertical portion, posterior loop, and the horizontal loop. It ends at the posterior edge of the line, and there is two major branches. One is for the vein artery, and one is the carotid. This is the overview, and then let's focus on the Petrous ICA, that you can see here. Petrous ICA can run up, and then the vertical segment, and the third and so this is the part exploded during the transplant. There's an intimate relationship with the GSPN and
Dr. Paolo, you are not audible.
no audible.
Yes, your voice is breaking in between.
I don't know how to fix it. Maybe it's problem of connection or it's just the audio.
No, it's better now.
Also, the connection is not good, or you can see everything well.
No, it's perfectly all right now.
Okay, so I was telling that the Petrous ICA has these three segments. One is the vertical segment, posterior band, and has a relationship during the anterior transmucosal approach with GSPN and facial. This is a zoom in picture of the vertical posterior band. This is the overview left side, so temporal approach. So you can see 7 ganglion P3, and here you have GSPN. If we dissect a little bit, you can see the Petrous segment basically inside the bone. Many times, 30% is uncovered by the bone, so it's already exposed. GSPN and Petrous ICA are not parallel each other. There is if
No, sir, you are not audible now. Again, I'm sorry. Can you restart your Zoom and come back, and Dr. Andrea can continue? Yeah, Dr. Andrea can give his talk first. Dr. Andrea, would you like to go on, like, share your screen? Hello, Dr. Andrea? Dr. Andrea, would you like to give your talk?
Yeah. I hear you well. Okay, I'm here. I start with my presentation, so.
Yes, please share your screen now.
So I share my presentation. Okay, can you see my presentation? Do you hear me?
Yes, sir, I can hear you.
Okay. Hello, everybody. My name is Andrea Bartolo. I'm an interventional neuroradiologist. I work with Paolo in Neuromed, and I thanked Paolo for the invitation for this speech about the radiological anatomy of ICA. And Paolo, in his speech, has talked about the previous classification of internal carotid artery. Now we will talk about a practical classification of internal carotid artery. Most of the images you will see in my presentation are taken from neuroangio.org. I recommend this site. It's a wonderful site about cerebral vascular anatomy. And we can divide ICA in several segments: the cervical one, the Petrous one, the cavernous one, the transitional one or clinoid one, the parophthalmic one, a posterior communicating segment, an anterior choroidal segment, and a terminal segment. So we start with the first ICA segment, the cervical one. It does not present circulateral branches, except in certain anatomical variants, specifically the origin of ascending pharyngeal artery and the origin of occipital artery. Less rare are the so-called loops, which probably represent a sort of embryological remnant. This is an example of a loop of ICA in its cervical segment. And occasionally, the cervical segment may exhibit an anomalous course, a retropharyngeal course, in which the ICA runs anteromedially, passing posterior to oropharyngeal wall, as we can see in this image. Patient, in these cases, may report a sensation of throbbing of the throat. Another important thing about the cerebral segment of ICA is web. What is a web? A web is a shaft-like narrowing of the carotid lumen caused by not an atherosclerotic plaque, but an hyperproliferation of connective tissue. So they are currently thought to be a variant of fibromuscular dysplasia. In most of cases, they are not a serious risk of thromboembolic complication, but sometimes webs can lead to embolic stroke, or less commonly to hemodynamic stroke. In this angiographic view, we can see the difference between atherosclerotic plaque on our left side of the monitor and of web in the right side of the monitor. We can see the web as a sort of knife that cut the internal carotid artery at the origin, a shelf-like narrowing of connective tissue. Aneurysms of cervical segment of ICA are rare. In most of cases are typically this dissecting aneurysm or pseudoaneurysm. We can move on the next segment of ICA, the Petrous one. It's located within the Petrous portion of temporal bone and in part within the Lacerum foramen. The alternate carotid artery enters into the cranial base, and we can divide this Petrous segment into three segments: the vertical Petrous one, the horizontal Petrous one, and the laterous one. The first is vertical, has a vertical course. The second has an horizontal course and anteromedial course. And finally, the last segment, the laterous one, has a vertical course. At this point, it passes beneath the petrolingual ligament. It's an important landmark that marks the entrance of the ICA in the cavernous sinus. Can you hear me? Can you hear me correctly? Okay.
Yes.
Okay, the petrolingual ligament is not visible angiographically, but we can imagine it with an imaginary plane passing tangentially on the petrous portion of the top of the temporal bone, and we can use a landmark to locate it. We can see this imaginary plane tangential to the top of the temporal bone, and so with this imaginary plane, we can image the petrolingual ligament in this site. The petrous segment of internal carotid artery may sometimes appear attenuated, so we can see in this image, due to the overlap of the petrous bone, especially when compared with the uniform contrast enhancement of the intracavernous segment and of the cervical segment, but it's normal, it's not pathologic appearance. It's crucial to not mistake for an opacification defect due to thrombosis. Petrous segment aneurysm can be of two types, essentially, post-traumatic aneurysms and other types of aneurysms. Post-traumatic aneurysms are, in most of cases, pseudoaneurysms. They are generally secondary to fracture of a cranial base involving a temporal bone, leading to fissuring or dissection of the internal carotid artery. Other types of aneurysms include primarily white giant fusiform aneurysms. They are often thrombosed and frequently extend into the cervical segment of the internal carotid artery, but rarely they surpass the petrolingual ligament. When the surrounding petrous bone is diffusely remodeled, the diagnosis is simple. We can do diagnosis even in a CT baseline scan. So this is an example of a wide giant fusiform aneurysms of the petrous segment of the ICA, and we can see how the cranial base, the skull base, remodeled by this aneurysm. In this case, this aneurysm has been treated with a flow diverter stent. So we can move on to the next segment. The anatomy of cavernous sinus and of the cavernous segment of the carotid of the ICA depends on the size and morphology of the cavernous sinus itself, which is an extremely variable anatomy in terms of both dimension and compartmentalization. So we can see in this image the cavernous sinus and so the cavernous tract of ICA. The uncertainty in identifying the distal boundary of the cavernous sinus has significant clinical and interventional implication. Why? Because this is important in determining whether a given aneurysm is purely intracavernous or, and therefore extradural, or parophthalmic and potentially intradural. In the cavernous segment of ICA, we can see sometimes some collateral branch, such as in this case, we can see Bernasconi cassinari arteries, which is a dural tentorial branch. And sometimes we can see the pituitary blush. So sometimes we can see the meningophthalmic artery, meningohypophyseal artery, and sometimes tronchoinferal trunk. The aneurysms of the cavernous segment expand laterally into cavernous sinus in most of cases. This is an example of laterally expanding aneurysm of cavernous sinus. And the clinical presentation of aneurysms of cavernous segment of ICA are common, are known. They depend on what the cranial nerve has been compressed, and in case of rupture of cavernous segment ICA aneurysms, we can have a direct carotid cavernous fistula. This is another example of cavernous segment laterally expanding aneurysms. Another example, in this case, treated with a flow diverter stand with a good result. Sometimes we can have cavernous segment medially expanding aneurysms. In this case, we can have a remodeling of sphenoidal sinus, and in this case, we can have also a brutal epistaxis. We can move on the next segment of internal carotid artery, the clinoid or transitional segment of internal carotid artery. It's a very short segment located between the proximal dural ring and the distal dural ring, and it is the last extradural segment. We can see a microsurgical image of the clinoid or transitional segment of ICA. Neurosurgeon knows well this segment and this anatomical region because of they have to do an intervention on clinoid, anterior clinoid process for treating an ophthalmic aneurysm, an aneurysm of ophthalmic tract of ICA. But medially expanding aneurysm of this carotid segment represent a special category, often classified as carotid cave aneurysms. These aneurysms are located in a potential space created by the redundant reflex of the dura mater adjacent to the medial wall of the internal carotid artery. They are located at the same level of dural distal ring. However, they are considered to pose a potential risk of subarachnoid hemorrhage in some cases. This is a carotid cave aneurysm, an example. So we can move on the next ICA segment, the ophthalmic or paraophthalmic one. It extends from the ostium of the ophthalmic artery to the ostium of the posterior communicating artery. The great enigma regarding this segment is sometimes not always contain the ophthalmic artery. Classically, ostium of ophthalmic artery is located just distally on 1 millimeter from the distal dural ring. However, it may occasionally originate elsewhere, either distally from the dural distal ring, from the arterial cerebral artery, or proximal from the dural distal ring, such as a clinoidal segment, or a proximal dural ring, such as cavernous segment. This is a case of a lower origin of the carotid of the ophthalmic artery. Another example of lower region, in this case, cavernous region of the ophthalmic artery, and is an aneurysm of the carotid of the ophthalmic tract of ICA. Another example with the 3D reconstruction. Aneurysm of this tract of ICA are very frequent. We can move to the next ICA segment, the posterior communicating one. So there are a lot of anatomical variants of origin of posterior communicating artery. We can have an hyperplasia of posterior communicating artery, or a fatal cerebral posterior artery with hypoplasia or aplasia of P1 segment of a cerebral posterior artery. The next one is the anterior choroidal segment of ICA. This refers to the segment of internal carotid artery adjacent to the anterior choroidal artery. Unlike the posterior communicating artery, which sometimes can be sacrificed in some cases, the anterior choroidal artery must be preserved because it's a terminal artery. We can see the choroidal artery. The choroidal artery sometimes is not a unique artery, but sometimes is a group of small vessels, even 4 or 5 small vessels with the same function. The terminal segment, beyond the ostium of anterior carotid artery, a small terminal segment of the internal guide leads to its bifurcation. From the terminal segment can arise perforating vessels, transversing the anterior perforating substance and supplying blood to hypothalamus, the basal ganglia, and internal capsule. These vessels are in hemodynamic equilibrium with the perforating vessel arising from the arterial choroidal artery and with the group of lenticulostriate arteries. In these cases, a moya-moya disease, we can see an hypertrophic perforating vessel arising from the top of the ICA. And so the terminal segment bifurcates, like we know, in anterior cerebral artery and middle cerebral artery. And the aneurysms of this segment tend to project vertically or the wise in another direction in the same direction of the internal carotid artery. This is an example of aneurysms of the terminal segment of ICA. So a complete knowledge of the neuroradiological anatomy of the internal carotid artery is essential for planning of neurosurgical and endovascular procedures. The identification of anatomical landmarks enables the prompt recognition of anatomical variants and supports informed therapeutic decision-making. The systematic division of internal carotid artery into segments serves as a useful framework for efficiently retaining critical information about this anatomical region. Thank you for your attention.
Thank you, Andrea. That was excellent. We will, Dr. Paolo Di Russo was able to reconnect, and he's going to try his talk again since you guys missed out. And I think I will go next, if that's okay, just because I'm at another meeting. So I will go next with the endoscopic approach, and then Dr. Di Russo will give his talk again afterwards. So let me just share my screen here. Okay. All right. So I'm going to go over some of the anatomical landmarks of the carotid via the extended endonasal approach and also ICA rupture management. And I'd like to thank my fellow Solomon and Renan, who have been doing a fantastic job in the lab and also with this presentation that they were helping me with. So, you know, you have this, we just went over some of this beautiful radiographic sort of images of the carotid. And so, and Dr. Froelich is going to go over how you see this from intracranial. But as you're thinking about the carotid artery endonasally, you always have to consider where it is on the endonasal approach and then where it is in comparison transcranially. So you always have to keep this three-dimensional picture in your head because what you, the landmarks are similar, but a bit different. So you have to sort of know it. And keeping these landmarks in mind. So we have the ascending or parapharyngeal portion of the carotid artery, the horizontal petrous, the lacerum and anterior genu of the carotid, and then the paraclinoid. We'll sort of focus in more detail all of these different segments. And these are the anatomic landmarks that we'll go over in more detail. So the parapharyngeal carotid artery. So essentially this goes from the common carotid bifurcation to the ICA foramen of the petrous bone. In the neck, it's going to run inside the carotid sheath, medial to the internal jugular vein and intermedial to cranial nerve 10. But really, when we're talking about the endoscopic endonasal approach, it's really the parapharyngeal ICA superior to the level of the hard palate that becomes relevant to this approach. And your landmark essentially is it's going to be posterior to the lateral most extent of the cartilaginous eustachian tube. So you have the cartilaginous eustachian tube here. And then posterior to the lateral most extent of this is where you're going to, if you draw a line back, you'll see the carotid artery, the parapharyngeal carotid artery is going to be right there. So this is with all the soft tissue removed. But you also, other landmarks you want to look at is the levator veli palatini muscle, which you see here, and this is attached to the eustachian tube. And then if you look at the fossa verosimillar, which is here, just deep to that, on the deepest aspect, if you follow that posteriorly, and you can see the same thing here, if you follow that posteriorly, you'll find the parapharyngeal carotid artery. So you want to keep your landmarks in place, and that includes the eustachian tube, the levator veli palatini, and the fossa verosimillar. So here we go again. It's located in between the levator veli palatini and the stylopharyngeal muscles, and it is covered by this thick basopharyngeal fascia that you have to go through in order to have full exposure. And so here is with the eustachian tube cut, and you see the levator veli palatini muscle here, and you're going to see the parapharyngeal ICA just deep to that, and attaching to this basopharyngeal fascia. And importantly, this parapharyngeal tubercle is a really good anatomic landmark. So if you draw a horizontal line across the parapharyngeal tubercle, what you'll see is that leads you to the carotid foramen. So it's a good landmark for the identification of the distal parapharyngeal ICA, and it's really in a straight line on both sides. And here it is again, and you can see the carotid foramen here as well as on this side. So when you identify that parapharyngeal tubercle, once you've gone through that basopharyngeal fascia, you can go here, and then you'll find the carotid foramen. Then heading over to the Petrous segment of the carotid. So this segment goes from the carotid canal of the Petrous bone to the posterolateral aspect of the foramen lacerum. Distal to that, it really is just going to be just juxtaposing the clivus bilaterally. So it's kind of got this this three-point thing. It goes into a vertical. There's a vertical segment, a bend, which is the posterior loop, and then the horizontal portion. So we'll go over each of those. And your landmarks here is really going to be the Vidian canal. And you have to find the Vidian canal. And it's really the line of fusion between the pterygoid process and the floor of the sphenoid sinus. And I'll show you a picture of that. And then the pterygoid wedge, where the medial pterygoid plate meets the floor of the sphenoid sinus. And then V3 is also a good landmark. So if you go here, you essentially, the transpterygoid approach is really what allows you to have endoscopic access to this region. And the pterygoid process has the pterygoid bone has two processes, the sphenoid process and then the orbital process. And the sphenopalatine artery is going to go from the pterygopalatine fossa to the nasal cavity. And then the Vidian canal is going to be inside the pterygopalatine fossa. So if you remove the sphenoid process and the orbital process, you'll find the Vidian canal. And you'll have to drill all around. So this is the sphenopalatine artery. You want to coagulate and cut the sphenopalatine artery, and then that's going to allow you to go to draw to here's your Vidian canal, and you want to drill circumferentially around the Vidian canal. And then once you get to the Vidian canal, you'll get to the pterygosphenoidal fissure. And once you get here, this is kind of the safe entry zone to the lacerum segment of the carotid artery. And so it creates this 15-degree angle here. This is a nice imaging picture of that, the pterygoid tubercle, which is going to be a 45-degree angle between the Vidian canal and the pterygosphenoidal fissure. And that really provides you the safest entry zone to the lacerum segment of the carotid artery. So keep that in mind. The foramen lacerum is really going to be that gap between the sphenoid, the petrous, and the clivus. That gap forms the foramen lacerum, and you want to enter that at the safest entry zone, which is going to be at the pterygoid tubercle. So this becomes a very important landmark to be able to find that anterolateralmost aspect of the foramen lacerum segment. Then we get to the paraclival carotid artery, and this goes from the posterolateral foramen lacerum to the superior edge of the petroclival fissure. And there, this is an important part. You got to identify the bony landmarks as well as the soft tissue landmarks, and that's important throughout the whole endonasal approach. Essentially, what you have here is, so you have your maxillary strut, right? That's a bony landmark that we know, and we have the lingular recess. And the lingular recess is really going to be what you intracranially, and I think Dr. Froelich will point this out, is intracranially corresponds to the lingular process of the sphenoid bone. So the pneumatization of that is this lingular recess here. And so if you draw a horizontal imaginary line proximal to this line along this lingular recess, you're going to have the extracavernous segment of the paraclival carotid artery, and then distal to it, to this imaginary line of the lingular recess, you have the intracavernous segment. And then intracranially, if you think about that, the petrolingual ligament is going to connect the lingular process to the petrous apex and marks the lower margin of the cavernous sinus. So you have to think about, you know, what this lingular recess here corresponds to intracranially, and that's the lingular process. And intracranially, we'll see the petrolingual attachment, and that really marks the entry of the carotid artery into the cavernous sinus. So, so again, the configuration here around the Lacerum segment, it really sort of acts like a foot in a sock, which is why it's actually called this ICA sock. This is a paper from Amin Kassam describing sort of these different segments, and it really describes this thickened sort of fibrocartilaginous band around the ICA, which is the ICA sock. And it is an important landmark for identifying the proximal part of the paraclival ICA, especially if you have, you know, not poor pneumatization of the sinuses, you depend more on the soft tissue exposure. What are the cranial nerves that are associated with the paraclival carotid artery? So mostly cranial nerve 5 and cranial nerve 6. So cranial nerve 5, you can see that proximally to the upper edge of the petrolingual ligament, the paraclival ICA is going to be medial to the lower 2/3 of the Gasserian ganglion, and then more rostrally, it's going to enter the cavernous sinus. Importantly, the cranial nerve 6, you know, there's different segments that you can see through the endonasal approach. There's this sternal segment, then there's this intradural segment, and then it bends over the petrosal process of the sphenoid bone to go almost horizontal behind the ICA, and then goes up in towards Dorellus canal and then into the cavernous sinus. So those are the two cranial nerves associated with this region of the paraclival carotid artery, and you can see it here sort of making this bend over the petrosal process of the sphenoid bone. And that can be actually identifying the nerve here where there is a bony landmark allows you a little bit of safety when in protecting the sixth nerve. Then you get to the paracellular region of the carotid artery. So from the supermedial portion of the petrous apex to the proximal dural ring. And actually, this part of the carotid artery is more widely separated from the carotid sulcus. The other parts are more surrounded by bony landmarks. So this is kind of what we would describe a little bit more of the free-floating carotid artery. And some landmarks are going to be the sellar floor and the petrous apex here. And it's the only segment that's really located inside the cavernous sinus. And then within it, the contents within this region of the cavernous sinus, medial to the paracellar, is going to be the venous component of the cavernous sinus, and you have all of the different paraclival ligaments, which you have to be able to cut through in order to resect the medial wall of the cavernous sinus, and those have been nicely described. Then lateral to the paracellar ICA is going to be where the abducens nerve passes, and it's going to be adherent to the vessel on this surface as well. And then even further laterally is where you find the other nerves that are going to control extraocular movement. Then you get to the paraclinoid segment of the carotid artery. And again, important to identify both bony structures as well as the fibrocartilaginous structures. So some of the important bony structures that we find here, or some of the important structures we find here, is going to be the medial and the lateral OCRs. And the lateral OCR being the pneumatization, this triangular shaped pneumatization that represents the optic strut when you're thinking about it intracranially. Then you have the medial OCR, which is this teardrop picture here, and it's formed just at the medial junction of the paraclinoid carotid canal right here, and the optic canal. Importantly, you want to think about your lateral tubercular recess, which corresponds to your tubercular crest intracranially, and that's the bony indentation at the lateral most extent of the tuberculum sella. And then finally, you want to identify the distal osseous arch of the carotid sulcus, which is going to connect the lateral tubercular recess to the medial aspect of the lateral OCR, and it kind of overlies the distal dural ring right here. So that it's that bony, this is kind of what we call the distal osseous arch of the carotid sulcus. Always keeping in mind what these things relate to intracranially, and I think we'll go over that in more detail. Then the proximal dural ring, important to know that it's an incomplete and incompetent ring. It does not fuse tightly with the arteries adventitia. And the distal dural ring is more complete. The proximal dural ring can be, if there's a middle clinoid, there will be a more thickened band, and therefore the proximal dural ring can be more complete if the middle clinoid is present or if the middle clinoid is more prominent. The distal dural ring, in contrast, is complete and it fuses tightly with the arteries as adventitia. And then immediately distal to the distal dural ring, you see the ophthalmic artery takeoff, as we saw in the last presentation. So importantly for your approaches for each of these, if you're talking about the parapharyngeal artery, you're really talking about the lower 1/3. So you're talking about your transcrival, transodontoid. If you're doing the endonasal approach, the Petrous, you're talking about infratemporal fossa, but you can also actually do the far medial approach that was described by Gardner's team, but that will get you to your Petrous carotid artery and allow you to be able to mobilize the carotid artery laterally if you do a Petrosectomy. Your paraclival, you're talking about your transclival approaches, and then finally paracellar and paraclinoid. Those are going to be your transcellular, transtubercular, transplanum approaches. So here's just what everyone's sort of looking for. I'll fast forward through the beginning of this, but this person had been previously operated on transcranially, and unfortunately was blind in one eye and was worsening. The vision began to decline in the other eye, and so then we're doing a transplanum, transtuberculum approach, and you'll see here that one of my fellows gets into the carotid artery. And so let me fast forward because the approach is not so important, but we want to talk about how to manage these, right? And so you'll see that is drilling with a diamond drill there. And it's important to notice here because a lot of these expanded approaches, we're doing, there's not a big mass expanding the sphenoid sinus. There it is. So oftentimes the anatomy is not so clear cut, right? It's not like a big pituitary gland. And so it's not so clear cut. And so you have to be very careful. So you see here that there's an ICA injury right there. And at that point, you want to get, there it is. You want to hover your suction to see where the injury is, right? If there's that patty is altogether way too big, but you want to hover your suction to really see what the injury is. Most of the times, if you try to coagulate or if you try to put any sort of mechanically stop this, oftentimes you end up making the hole bigger. There are very few times in which you can actually clip, put an endonasal clip if that's the case. But what you want to do is, obviously get the bleeding under control, let the anesthesiologist know. This is a piece of crushed muscle that works very well, and you want to sort of switch out your patty for the crushed muscle and then go directly to the endovascular suite. So here's an example of the muscle. You also want to be, interestingly, you do want to give heparin. You don't want to forget to do that, right? And you don't want to occlude the vessel too much. So you want to really hover your suction, see where it is, put a patty on briefly just to control the bleeding while you're able to switch out for that muscle. So now that there's muscle there, I'm going to put a Maricel in there to be able to go to the endovascular suite. I keep a patty on top. I go to the endovascular suite. And this person ends up getting a stent across. They ended up getting one of those cardiac stents, so dual antiplatelet. And interestingly here, the angiogram didn't show any defect, but don't be, if you saw a carotid injury, don't think that, oh no, it's fine and go back in. If you saw carotid injury, you definitely need to fix it. There are some people who say, well, maybe you can just get an angiogram in a week, but oftentimes you'll see a pseudoaneurysm. Those are very high risk of rupture. So I think it's safest if you see a definite injury to go ahead and put a stent in. And this is the stent that this patient had placed. Obviously, we were not able to remove the tumor, and because of the stent, it's a covered stent. So this person ends up getting dual antiplatelet for 6 months, and then we'll come back in and replace and take out the tumor, probably transcranial at that point. But a couple important points from this video is, when you're doing these tumors that you don't have great landmarks, you have to be very cautious. And when you do get an injury, you want to really control the bleeding, put some muscle, and you got to remember to tell the anesthesiologist to give heparin. So how do we prepare for this? The best way I think is to prepare through this via the carotid injury model. And this was widely described by Gabizada and his group. They really created this perfusion-based human cadaveric model for management of carotid artery simulation for the trainees. So the objective really is to train residents so that when this happens intraoperatively, it's not the first time that you've experienced this or that you've dealt with this. And so the materials that you need, you're going to need a fresh, unfixed cadaver head. Do this pretty easily, but you do have to have a perfusion system that allows you to pump blood substituting through the carotid. So you access the carotid in the neck and you create this perfusion system. So here's an example. Here's the perfusion system connected to this patient's neck. This is the head here. And then the session begins. I actually went in and I created a carotid injury, and then you begin training for this. So you have, I did the exposure, I did the approach, and then there's going to be the trainee who's going to come in, right? And then at the same time, we are monitoring the vitals of the supposed patient, right? With EKG, pressure, and heart rate. And then if they're not able to get this under control within 5 minutes, the patient, goes ahead and dies. So we have this training model. This is one of my trainees, and the injury is already made in the carotid artery, the perfusion system set up. And I'll show you just a video of that. And again, the technique is really to replace the suction with a large bore suction. That's the first thing you want to do, and that saves time in the long run. And then hover the suction to attempt to visualize the injury, place the patty, and then go ahead and switch it out for your crushed muscles. So I think this video will pay. Here we go. So that's the injury there. So you can see that it's very quickly fills up with blood. Some of the trainees won't switch out the suction right away, and that's actually a mistake. So you do want to switch out to a large bore suction, right? Then you want to communicate to the anesthesiologist that you've had a carotid injury, get blood available in the room, and actually give heparin. And you want to hover it over the injury to be able to see exactly where it is. In the meantime, somebody is getting the crushed muscle, and you're going to put a patty there, and then switch out the patty for the muscle. So the patty is there, you know exactly where your injury is, you're able to get the bleeding under control. As you can hear, the patient starts to, the heart rate starts to go up and the pressure starts to go down as time passes, sort of simulating a real life. Okay, so here's a piece of crushed muscle, and the idea is that you're going to switch out the crushed muscle, which, yep, this can happen. And then, yep, now the crushed muscle is directly over the injury. And once you clean up the field, that's considered, a successful repair of the carotid injury. So this is, I think, a very useful training model. We kind of timed them. So you do this twice. Once you do it initially, and then you hear about what the technique should be in terms of the hovering and switching it out for the muscle. You learn the technique, and then you do it again. And what we found is that the time to control the bleeding improved by almost 50%, and the amount of bleeding reduced by about 50%. And this is exactly what they found in Dr. Zada's experience as well. So this is something that we've done in our lab maybe once a year, once every other year, to train our residents. But importantly, you have to go to the lab to learn these anatomic landmarks, learn where there can be injury, and then, use this carotid injury model to prepare and prevent disaster when this happens intraoperatively. So I'll stop sharing my screen. I think now, if Paolo, if you're able to go again, I think that would be great, because you had some great content there and we missed out on most of it. But maybe you can start after the classifications. I think we heard most of the classification.
Can you hear me now?
Yeah, we can hear you now.
Seems better than before.
Yeah, much better. Not breaking up at all, actually.
Okay, so let's try. Thank you.
Perfect.
Okay. So let's try again. Okay. So can you hear me? No. So let's
Yes, we hear
start
you.
again with the anatomy of the carotid. The classification already tried to tell before, and both Andrea and Carolina told something about the classification of the carotid. So let's start with the anatomy. This is a left side representation of the carotid on a cadaver. As you can see, to show the whole length of the internal carotid artery, intracranial carotid artery, you need to cut the nerves, to open the bony corridors, petrous and clinoid, and to remove the blood vessel, the venous blood channels and vessel. This is what does it mean. You understand immediately. This is the right side, that the whole carotid artery has an important relationship with the intracranial cranial nerves and bony structure as the petrous bone and anterior clinoidal process. So to show the carotid, for example, in this case, the intracavernous carotid artery, you have to open up the corridors and remove the blue material, which is the blood venous blood in the cadaver, to show the carotid. So I will use the classification of Boutillier that I told before, 7 segments in the direction of the blood flow. So I start with the cervical segment. Cervical segment of the intracranial carotid artery starts at the level of the bifurcation of the common carotid artery, more or less at the level of C4 cervical vertebra, and runs inside the carotid sheath together with the internal jugular vein, which is lateral, and posterolateral is the vagus nerve. More anterior is the external carotid artery, and cervical internal carotid artery ends at the level of the when it enters the carotid canal and become Petrous carotid artery inside the Petrous bone. There is no branches. There are no branches coming out from the C1 segment of the carotid artery. Just to show you the importance also of some branches of the external carotid artery, I show you just briefly. You can find some branches of the external carotid artery in the neck when you're doing some dissection for an ACADF, or with a more complex approach like the anterolateral approach for tumor of the upper cervical spine of the craniocervical junction. So you can see here the superior thyroidal artery, you can see the beginning of the lingual artery, and then here is the relationship between the internal carotid artery and the internal jugular vein, which is posterior in the carotid sheath. And then as we go up, you find the lingual artery, the facial artery, and the exit of the occipital artery here, which is being cut. This is a much more zoom-in images. And then another important artery coming out from the external carotid artery is the ascending pharyngeal artery that can give branches and feed petroclival tumors. So let's go to the second segment, C2 segment, Petrous ICA. Is it inside the carotid canal? Is divided into 3 portions. Is a vertical portion, a posterior band, a posterior loop, and horizontal portion. It becomes at the carotid canal. It ends at the posterior edge of the foramen lacerum, where it becomes lacerum carotid artery. 2 branches, small branches, Guedon arteries and carotid tympanic arteries. This is the view of the whole carotid. Let's zoom only on the Petrous ICA. You can see the vertical part of the Petrous ICA, the posterior band here, posterior loop, and the horizontal portion, which is the portion that is exposed usually during the anterior transpetrosal approach, and that has a closer relationship with the GSPN and genicular ganglion and labyrinthine portion of the facial nerve. This is much more zoom-in picture to see the relationship between GSPN and facial nerve and the horizontal segment. It's much more clearer to see on a cadaver in a surgical perspective. This is a left side subtemporal approach. You see V3, and if you dissect a little bit more this periosteum, you will see the Petrous segment of the ICA. You see that it's not completely parallel to GSPN, which create a little bit a small angle in between them, the different direction of the two structures. The Petrous ICA is related, as I told you, to GSPN, and when GSPN goes inside the facial hiatus, it has a relationship with the geniculate ganglion. If you drill up everything posteriorly, posterior to the cochlea, you will find also the last part of the Petrous ICA. And this is another picture to show you the relationship between tensor tympani muscle, the middle ear, which is more lateral with the Stauchen tube, and the GSPN. Again, another picture. Now this is still the left side, so we switch from the Petrous carotid artery to the Lacerum segment. The Lacerum segment maybe is the one that is not exposed during surgery transcranially, so it's much more difficult to understand, and is really behind the trigeminal nerve, the trigeminal ganglion. So it is in between the Petrous segment, which you can see here on top, on the left of the picture, and in the bottom on the right, the cavernous segment of the ICA. So Lacerum segment, C3 segment, it is not really inside the foramen lacerum, which is on the extracranial surface of the skull, but it occurs above the foramen lacerum. It contains the lateral loop of the ICA and goes in the direction of the posterior cavernous sinus. It ends at the level of the petrolingual ligament, which is the real landmark to define the two segment, cavernous segment and the lacerum segment. And it has no branches, no perforating branches. So again, this is the old view of the carotid. Let's focus only on the lacerum segment. The lacerum segment actually is completely surrounded on in all the surface from a periosteum tissue, is a fibrocartilaginous tissue that surround completely the lacerum segment, which here has been open to show the segment. Here you can see the sixth nerve. Sixth nerve is already inside the cavernous sinus, so the real finish is at this level here of the petrolingual ligament, which has been open. This is a more zoom-in picture to show this segment. This is a cadaver on the right side, subtemporal approach. You see the three branches of trigeminal nerve, Gasserian ganglion here. You see a little bit of the Petrous ICA, and it means that the lacerum segment is really behind the Gasserian ganglion and the trigeminal nerve. So if you remove, like in this case, you cut the trigeminal nerve, dividing the preganglionar fibers before the Gasserian ganglion, you can see the petrolingual ligament here and all the periosteum that is covering the lacerum segment of the ICA. And if you remove all this periosteum, you can clearly identify very well the petrolingual ligament, which is the ending point of this part of the carotid. And still here you see a little bit of periosteum covering the lacerum segment of the ICA, which is the third segment after the Petrous ICA, and is before the cavernous sinus, as you can identify here, because you see the sixth nerve that is inside the cavernous sinus. This is another picture, another cadaver, still on the right side, and you can see here the same on top on the right, petrolingual ligament and the periosteum. This is the limit of the lacerum segment of the ICA, and then here goes in the direction of the cavernous sinus. Cavernous ICA, one of the most studied segment of the ICA in the past. Nowadays is more land for neuroradiologists, but some is still useful for neurosurgeon to understand how deal with Cavernous ICA and mostly with the lateral wall of the cavernous sinus, which contains the cranial nerves. It starts at the margin of the petrolingual ligament, as we said, is composed of 4 portions: is a vertical portion, posterior band, horizontal portion, and anterior band, and ends at the level of the proximal dural ring, becoming Clinoidal ICA. Several branches comes out from the cavernous carotid, meningoepiphyseal trunk, infralateral trunk, capsular artery, conal, and sometimes, as Andrea Bartolo said before, the ophthalmic artery can have its origin inside the cavernous sinus. Again, the whole carotid, and then let's make a focus on the intracavernous carotid artery. So you can see the vertical segment, posterior band, horizontal segment, and then anterior band behind the third cranial nerve before becoming clinoidal ICA. You can see here this cadaveric picture on the left side, the meningohypophyseal trunk. This is on the right side, still an anatomical view. You see how the channels of the cavernous sinus, the fake channels of the cavernous sinus are created by both the cranial nerves and the areolar tissue that contains the venous blood. To see better the carotid artery, you need to open up the corridors. So you look here, the Parkinson triangle is widely exposed. As you can see the 6th cranial nerve, which is hidden by the 5th nerve, which is really inside the cavernous sinus. The 3rd and the 4th cranial nerve and the V1 branch of the trigeminal nerve are in the lateral wall of the cavernous sinus. This is right side. You see all the venous blue material has been removed to show the Castellan ganglion, and if you retract V1, you see the 6th nerve that is really attached both to C1 then with the sympathetic fibers to the intracavernous carotid artery. This is the horizontal segment. Another view, a little bit more with an angle. So still the 6th nerve and the horizontal segment, anterior band of the ICA inside the cavernous sinus. The Parkinson triangle has been widely exposed. This is instead a picture on the left side. Let's see the branches of the cavernous ICA, meningoepiphyseal trunk, really important because it gives you 3 important arteries: the Bernasconi artery, tentorial artery here, the dorsal meningeal artery, the inferior hypophyseal artery. Another picture always on the left side on another cadaver. You can see very clear the origin of the meningoepiphyseal trunk. The dorsal meningeal artery is much more related to the 6th cranial nerve. You see here the 6th cranial nerve inside the cavernous sinus below and behind V1 coming outside from the Dorellus canal. And instead the tentorial artery, Bernasconi canestinary artery, is much more related to the course of the 4th cranial nerve. And here is, as I was telling before, the 6th cranial nerve coming out from the Dorellus canal inside the interdural segment. This is still on left side, another cadaver, and here you can see the origin of the inferolateral trunk here, and all the origin and maybe a variation of the tentorial artery that run together with the 4th nerve. We can leave now the cavernous segment of the ICA. You can see is completely hidden and covering inside the venous blood of the cavernous sinus, and we jump anterior to the cavernous, the clinoid ICA, which is covered by the clinoid, anterior clinoid process, and then to the ophthalmic and intradural ICA. 5th segment, clinoidal ICA, very short segment. It's completely extradural and surrounded by the proximal and distal dural ring inside the space that is called the clinoid space or carotid collar. It is covered, the ICA inside this level, when you remove the anterior clinoid process, is surrounded by a venous channel which drains from the cavernous sinus, but it's not, the carotid is not intracavernous. It gives no important branches, the same, the whole carotid. And then let's focus on the clinoidal segment of the ICA. Here you can see the clinoid has been removed and the distal ring has been opened, and you can see clearly between the optic nerve and the third cranial nerve, one is superomedial, the other one is infralateral. You see the clinoidal ICA. You see here the Cavernous ICA coming in the direction of the clinoidal ICA. Another picture, old picture of me from New York. You see all the course of the bending of the intracavernous carotid artery, then the clinoidal carotid artery covered by the periosteum of the carotid collar, the ophthalmic artery, and then the intradural portion of the artery. This is a much more zoom-in view, always on the anatomical perspective on the left side. But to see the clinoidal ICA, you need to drill out and remove the anterior clinoid process. This is left side, some temporal, frontotemporal approach. You see in transparencies all the nerves inside the cavernous sinus covered by the periosteum of the lateral wall, the cavernous sinus, the third nerve here, and the big anterior clinoidal process. You drill out progressively the anterior clinoid process, and then at the end you see clearly the cavernous ICA. You see a little bit of venous bleeding, venous blood here that is draining from the cavernous sinus. When you do the anterior clinoidectomy, you definitely do also the unroofing of the optic canal, which is one of the goals of the anterior clinoidectomy. And in this cadaver, you can see very well the origin of the ophthalmic artery behind and below the optic nerve. This is a picture just to see that the carotid artery is completely surrounded by this venous channel. Let's jump to the ophthalmic segment of the C6 segment of the carotid artery. Also a small segment, begins at the distal ring and then ends just proximal to the origin of the posterior communicating artery intradurally. It runs below the optic nerve in the intracranial portion, and then becomes progressively intraorbital, going to vascularize the optic nerve and the other structure of the orbit. Two major branches important in this segment. One is exactly the ophthalmic artery, and the other one is the superior hypophyseal artery. Still the general view, and then a focus on the ophthalmic artery on the left side, the anatomical view. You see is below, his origin is below the optic nerve, and then goes inside the annulus in, and then it goes inside the orbit here, and you see all the branches of the ophthalmic artery vascularizing the optic nerve and in generally the structure of the orbit. Another picture to show the ophthalmic artery is from behind. You see you can cut and elevate the optic chiasm and elevate the two cranial nerves. Both sides you see the origin of the ophthalmic artery from the ophthalmic segment of the ICA. And this picture we already saw after the distal ring. You see clearly the ophthalmic artery starting from the carotid and running below in the direction of the orbit below the optic nerve. The ophthalmic artery actually is at risk if you need to cut the falciform ligament and the distal ring. When you do the proximal cut, you risk to injure the ophthalmic artery, which runs exiting this point here. So you cut the falciform ligament and you see the ophthalmic ICA. This is really already intradural, and then you have your distal ring. When you do this cut of the distal ring, you risk to injure the ophthalmic artery. You want to look at the origin of the ophthalmic artery before doing this cut of the distal ring. And then this is the carotid and ophthalmic segment, and the clinoid segment completely exposed. So let's go to the last segment, the intradural ICA C7 segment. Begins after the origin of the posterior communicating artery PCom and bifurcate into the anterior and the middle cerebral arteries. Two major arterial branches. One is the posterior communicating artery, and the other one is the anterior choroidal artery. This beautiful picture from Gian Domenico Petrella show us the in anatomical view from anterior to posterior the origin of the intracranial portion, the carotid ICA, and its bifurcation into the anterior and middle cerebral artery. This is from on the left side, lateral view. You see the bending of the intracranial portion of the carotid artery and the origin of the perforators of the bifurcation of the carotid artery. Let's focus a little bit here. You see all the perforators coming both from the bifurcation of the ICA and both from the anterior choroidal artery. We will see a little bit more in other pictures. One as the first segment inside the intracranial portion of the ICA is the PCom, posterior communicating artery. This is nice in this cadaver, in this superior posterior view. You can see a variation of the PCom. On the left side, you see a classic PCom going from the ICA to the PCA, and then on the right side, you can see a fetal PCom that is with a wider diameter going directly inside the PCA. This is much more clear on the right side. This is another view from anterior to see a little bit more the bifurcation of the ICA. This is from superior and from anterior. You see the carotid artery, which is lateral and a little bit inferior to the optic nerve, and bend a little bit laterally and then bifurcate into the MCA and ACA. And here posterior, you can see the origin of the anterior choroidal artery that goes posteriorly in the direction of the choroidal plexus and giving perforators that we will see later. This is a much more zoom-in view of the anterior carotid artery, anterior cerebral artery going up and creating the anterior communicating artery joining the contralateral side. Let's focus on the anterior choroidal artery now. We will see a little bit more later the perforator. So the anterior choroidal artery, you see in this nice picture that runs parallel together with the optic tract. It gives you important perforator branches to the optic tract, not only, but also inside the anterior perforated substance to the capsula interna. This is a more oblique view, and you see clearly the branches to the optic tract. You see also the third nerve lateral to the intracranial carotid artery and in between the SCA and PCA. This is a much more zoom-in view of the perforators from the anterior choroidal arteries. This is a much more surgical view, right side, pterygoidal approach. The cervical fissure has been completely open. And so this is the view, classic view that we see, intracranial portion of the ICA, origin of the PCom here, that is joined, short PCom here, this is joined the PCA, and the bifurcation into the A1. And then you can see the A1 here very clearly, and then you start A2 and the Oibner artery. It's very nice on the cadaver going inferiorly inside the anterior perforated substance. Here from this view, we can see better the relationship with the third cranial nerve and the PCom origin. PCom has some perforators. It's variable the number of perforators, but as you can see in this cadaver, 2 or 4 perforators are usually present around PComA segment of the ICA and also directly from PCom. Another view here of the chiasm, a little bit more angled toward the midline of the microscope. This is another view, more subtemporal view, where you can see more clearly the origin of the PCom and the perforating branches coming out from PCom. You look at this big perforator coming out from PCom. This is PCom then in the PCA, and then this is the region of the anterior choroidal artery. The anterior choroidal artery also can give perforator, as we saw in the previous cadavers, and they can have also 2 different origin. We can have 2 anterior choroidal artery, as is seen clearly in this cadaver. This is an overview, the whole segment of the intracranial carotid artery. The clinoidal is no more present. Here you see the intracavernous portion here of the carotid artery, the siphon carotid intracranial portion. I think I finished, so you could hear me very well. So Sebastian, maybe it's your turn. Everybody fall asleep, maybe. Let me call in.
Okay, Paolo, it's fine. It's fine. It's fine.
Great.
Hello. Sorry for being late, as usual. I'm really not good at at all this. It was nice. I started when you connecting when your colleagues from radiology start his lecture, so I followed everything.
Okay.
So it's my turn now. I will let me hold on. How should I do that? I'm not so good. Can you see my presentation?
Yes, just run the presentation. Run as a presentation. It will be
good
on the white screen. Yeah.
Okay.
Good.
So subject of my talk today is to discuss about exposure of the ICA through transcranial approach. I think you already talked about the classification. I have to say this is a classification I use on a daily practice. It's a classification from Cincinnati which goes with the flow, because you know that there is classification who goes reverse, which to me doesn't make much sense, but I believe you have discussed already all this. This is drawing from Kentaro Watanabe showing the different segments, and I will go over all those segments during my presentation, trying to show what type of exposure, what type of approach you should use for the cervical segment, for the Petrous segment, Cavernous segment, Clinoidal segment. What are the indications for transcranial ICA exposure or control? It's mainly when you have a tumor that encases the ICA or infiltrates the ICA, or in a complex vascular lesion. And here there is two scenarios. Either you want to have this control because you want to preserve the ICA, so you want to control it in case of intraoperative rupture, for example, or you want to expose because you are planning to sacrifice the ICA to take it out if you want to do a cavernous sinus exenteration for an aggressive meningioma, for example, or if you want to sacrifice it because you're planning to do a bypass and you will occlude part of the ICA to occlude the aneurysm after doing a bypass. In case of ICA tumoral involvement, there is different options. You can either leave a piece of tumor adherent to the wall. This is fine for vast majority of diagnosis. For example, some meningioma, it's not a big deal to leave a piece. When you have a clinoidal meningioma infiltrating the ICA, we leave pieces of tumor if it's highly adherent. You can try to separate the tumor from the wall, but in this situation, you need to have a backup plan if there is a rupture. So the best is to have control and to be able to reconstruct or to do a bypass if it's the risk is significant of a rupture. You can do a balloon test occlusion to have an evaluation before if you can sacrifice in case you have an issue trying to resect this piece from the wall. If the patient fails the balloon test occlusion, then you need to be prepared to replace the ICA. Either you do a protective bypass if the risk is extremely high, or you do a bypass once you have an accident, which is definitely not the best option. There is also the options to reinforce the ICA with a stent before the surgery. This is sometimes done for paraganglioma, for example. Few tips and tricks when you work next to the ICA. When you drill the bone over the ICA, Petrous apex or clinoid process, you should never use anything else than a pure diamond burr. Coarse diamond are like cutting burr. If it's next to the wall of the carotid, you will open it. Continuous irrigation is extremely important, even next to the carotid, because if the drill burns the wall of the carotid, it can also open the carotid or fragilize the carotid. When you drill next to the carotid, you should use large burr as much as possible. The smaller is the burr, the more difficult it is to control the burr. And you need, again, strong irrigation, and you shave the bone parallel to the axis of the carotid without pushing on this wall to avoid, obviously, losing control and eventually entering into the carotid. I will not talk about the cervical ICA. Carolina has shown some nice landmarks when you go endoscopic. Just be aware of variations of the cervical segment of the ICA. Look at this CTA. There is double loops. Sometimes this loop crosses the midline at the level of C1 anterior arch. So if you do a vertical incision, you can enter the ICA. It's not very often, but it happens. About the distal segment of the ICA, the distal segment of the ICA is a segment that is after the digastric muscle. Once it crosses the digastric muscle to go to the carotid canal, this is considered as a distal segment of the ICA, and it's probably the most difficult segment to expose of the ICA. You can see here on this dissection, we are at these 4 segments. These come from studies that Frederica Beretta has done in Cincinnati after I was there, trying to show what can you gain with additional technical steps to expose the last segment of the ICA before the carotid canal. You can see here hypoglossal nerves, the bifurcation, the ICA here, internal carotid, and you see here 9. Those last 2 centimeters can be extremely challenging to expose. So you need a good reason to do that. This is related to the parapharyngeal space. The parapharyngeal space is very deep, very complex, very rarely exposed during surgery. But still, you need to have an idea of this parapharyngeal space. This is dissection of the skull base from below. We are looking from below. So here you have V3 coming out from foramen ovale with the branches of V3 just after foramen ovale. You have here middle meningeal artery. You have here tensor veli tympani muscle, levator veli tympani muscle, Eustachian tube. And here you have this exit, this entry segment of the ICA into the carotid canal. So you see that it's very deep in a highly complex region. Here it's a more detailed view showing you the relationship here of the Eustachian tube. Here you have the vaginalis process, which is a spine of bone lateral, forming the lateral aspect of the carotid canal at the point where it starts in the inferior skull base. And this is an important bone process because in some approach I will show you, we drill it to expose this final centimeter of carotid canal. Here you have the spine of the sphenoid, which is between vaginalis process and middle meningeal artery, spinosum foramen. It's also something that you have to drill when you come from lateral to medial to expose this ICA. So the roof of the parapharyngeal space, I will not go into details, is limited anteriorly by the scaphoid fossa. Laterally, it's the spine of the sphenoid. Posterolateral, a little bit more backward, it's a styloid process. Medial, it's a medial margin of the carotid canal. And posteriorly, it's the margin of the jugular foramen. The approach to expose these segments, the traditional approach, where the fish approach, type B, C, D, it's mainly transpetrosal approach, which include manipulation of the fascial nerve. So we come from lateral, we have to deal with the fascial nerve, we have to deal with the middle ear. So the patient in those operation was submitted to a significant risk, if not always postoperative fascial nerve palsy, at least a grade 3, when the fascia was taken out from the fallopian canal. Patient loses also hearing. This is a detailed picture of it. Sometimes you cut V3 to get to this final segment. Another option is approach described by Shekhar, subtemporal preauricular infratemporal approach. There is definitely less fascial nerve manipulation, but still some manipulation at the level of the parotid. For the fish approach, it's more into the petrous bone. Hearing is preserved because there is no section of the external auditory canal, but with this approach, you have to dislocate the TMG and sometimes to remove the condyle. So quite morbid approach, both. It's approach that I am not using very often, obviously, but the subtemporal preauricular infratemporal fossa approach sometimes, mostly in case of malignancy. So in classic skull-based surgery, when we deal with meningioma, for example, or malignancy of the cavernous sinus on petrous bone, I have to say I am more in favor of other way to have the control of this distal segment of the ICA and vertical segment of the Petrous ICA using anterolateral approach or the transpinosome corridor, which I tell you more about in a second. So the anterolateral approach is definitely great to have access to this final segment of the ICA. It's an approach from Bernard George. It's anterior to the sternocleidomastoidean muscle. You have to detach this muscle from the mastoid, from the occipital bone, as you can see here. You detach also the splenius muscle, the nuchal muscle, to have an exposure of the suboccipital triangle. You have the 11th nerve that cross this fat pad below sternocleidomastoidean muscle. You have to identify this 11th nerve and you have to push it downward. You expose the digastric triangle, the suboccipital triangle with inferior oblique, superior oblique, rectus capitatis major, or superior oblique, inferior oblique attached on the transverse foramen of C1. This is an extremely important landmark. This approach is not done for control of this distal segment of the ICA. It was designed to reach the craniocervical junction, the jugular foramen controlling the vertebral artery. But still, the principle is the same for the access to this distal segment of the ICA. If you want to have access to this distal segment of the ICA or the lower cranial nerves that exceed the jugular foramen, you have to take out the digastric muscle to transpose the digastric muscle inferiorly, as it is shown here, which gives you more access superiorly, anteriorly of this parapharyngeal space. When you do that, be aware that the facial nerve is just in front of the digastric muscle. You have to be careful, especially with coagulation. So as I told you, the anterolateral approach is made also for the exposure of the vertebral artery. I will not go into details of this because this is not the subject of our lecture. But that's the final view of an anterolateral approach. And you can see here that we have a nice access to this distal segment of the ICA. If you work in front of the jugular vein, if you identify the 12th nerve, if you go up along the carotid artery, you may find 9, but 9 is very deep. But at the end, you can have access to this final segment. I show you a case where I expose this final segment of the ICA. It was not to control a tumor. It was just surrounding this chondrosarcoma, an extensive tumor going from the petrous apex to the neck. We thought a lot about the approach. He had a previous operation with an anterior petrosal approach. The tumor was cut in 2 pieces. So for all the inferior part coming from here down to the neck, we decided to do this anterolateral infralabyrinthine approach, multiple corridor, to take everything out except the part in the cavernous sinus that we took out with an endonasal approach later on. So this is the exposure, this anterolateral approach. I am here drilling the petrous bone, doing an infralabyrinthine approach. I open here the jugular foramen. And here I am dissecting in between the jugular vein and the lower cranial nerve. And I figure out, and this is very interesting, I try to show you that more slowly. I figure out here that the tumor is very soft. So instead of dissecting in between the lower cranial nerve with my microscope, I decided to put an endoscope inside from down up in between the lower cranial nerve. And you can see here, it's a quite unique view because this is not something we see very often. That's the lower cranial nerve coming out from the jugular foramen, seen from below, and the carotid artery is here behind with an endoscope. The tumor here is a little bit more posterior, obviously. I am sucking it from down up. I am not using right now the infralab corridor. And you can see here this beautiful ICA coming into, going into the carotid canal. Again, it's a quite unique view of this ICA going up. For the rest of the tumor here, we used the infralabyrinthine corridor to take the tumor out, and also this corridor below the posterior semicircular canal, which can lead to the petrous apex. And you can also have here an access to the Petrous ICA. This is using the endoscope through the infralabyrinthine corridor, and you see that we reach here also quite anteriorly. We took almost everything out except again this part in the cavernous sinus that remained and that we took out with an additional surgery for endoscopic endonasal. Another way to expose this distal cervical ICA and also the vertical segment of the ICA is a transpinosome corridor. I used it maybe 4 or 5 times in my practice, so it's very rare, mainly for malignancy. When you want to have the proximal control of a malignant tumor, epidermoid that you need to take out en bloc, petrous bone epidermoid, it's not so often, but it happens in few occasions. And I have to say, it can be nice to have this control. So this corridor is a corridor that goes subtemporal. You drill the temporal fossa floor and you expose the carotid through the temporal fossa floor. This is a little bit of anatomy of this region. We are on the left side. We are looking it through a subtemporal approach. So here is V3, here is V2. Here are the division branches of V3. You have the lingual nerve here. You have here middle meningeal artery going through foramen spinosum. Here you have behind the tonsor tympani muscle, which is superior on medial to the osseous portion of the Eustachian tube. The middle ear here is open with the malleus, and you have this tiny nerve here running above, which is the chorda tympani. Then it goes down through the spine of the sphenoid and exit to join the lingual nerve. This shows you also a nice, interesting fact that when you coagulate the middle meningeal artery too strongly, you can burn also the chorda tympani, which runs sometimes very closely to foramen spinosum. This is histological slices to show you, this is coronal slices to show you how close all this runs together. This is VIG3 extracranially, middle meningeal, and here chorda tympani into his canal. Sometimes both foramen are fused or chorda tympani crosses foramen spinosum. This is a view also, I don't know if it's coronal, it's probably more sagittal here, showing the cochlea. You see how close the carotid artery, Petrous ICA, when it become from vertical to horizontal, how close it is from the cochlea. Sometimes it's less than a millimeter. And you see here the Eustachian tube, osseous portion of the Eustachian tube, cartilaginous portion, and you have here the ICA that start to turn. This is the vertical segment of the ICA. We are just here at the turn, vertical, horizontal. This is the genu. Look how close is the cochlea from the genu. It's probably less than a millimeter here. This is V3, not yet through foramen ovale, and this is the cartilaginous portion of auditory tube. This is beautiful slices which give you another dimension of anatomy, more precise to understand the relationship with the structures. So the transpinosum corridor is a corridor that you access through a subtemporal approach. You can do a frontotemporal craniotomy with also extending down towards the temporal fossa floor. You drill until you find V3 foramen ovale. You drill until you find middle meningeal artery. This is a line of sight. Frontotemporal with a temporal craniotomy extension. This is great. You get the proximal control, but you can also work on the tumor, which is distal to this segment of the ICA. So this is a classic view, you know, with an FTOZ. There is orbit, frontal dura, temporal dura. This is V3. This is middle meningeal artery, just immediately lateral and behind it. So for this approach, you have to go through foramen spinosum. So you have to cut middle meningeal artery to drill completely the foramen, and just behind and below in the inferior surface of the skull base, you have the spine of the sphenoid I told you about, through which chorda tympani runs like this. It does like a kind of S. So when you do a transpinosum corridor, you sacrifice the chorda tympani because you go through the canal. You take out first the spine of the sphenoid. You have to peel the lateral pterygoid muscle being superiostal from the temporal fossa floor. This is key, because if you open this periostom here that covers the inferior surface of the temporal fossa floor, you will get profuse venous bleeding. So you have to keep this periostom intact. You take the spine of the sphenoid out, and a little bit behind it, deeper, I would say, deeper, it's quite a deep corridor, you have the vaginalis process. Vaginalis process is variable in shape. Sometimes it's very small, sometimes it's longer along the lateral aspect of the ICA. You have to check this on the CT scan. Not to be surprised that, in fact, it's much bigger than what you expect. Once you have drilled the vaginal process, you expose the carotid sheath that surrounds the ICA. You're next to the ICA. Doppler is very useful. And then you have to dissect into the neck, following the wall of the ICA. You don't want to dissect too deep into this complex area. You have the lower cranial nerve not so far behind. but you can have an access to probably around 1 centimeter of ICA before it enters the carotid canal. You can also combine it with an exposure of the horizontal segment of the Petrous ICA. So here we have everything. We have done a small drilling of the anterior aspect of Kawase to expose this Petrous segment of the ICA. In between, what do you have? Between this cervical segment, vertical segment, and horizontal segment, you have something crossing. This is the Eustachian tube on the tensor tympani muscle. So if you want to completely free this ICA, you have to go through the Eustachian tube on tensor tympani muscle. If you do that, the patient will have an otitis media and he will need a tube, a tympanic tube. This is another dissection in the other side, showing you the same. So middle meningeal artery, you go through middle meningeal, you expose the spine of the sphenoid, you take the spine of the sphenoid and the vaginal process, and you have access to the ICA. It's not an easy corridor. It's not an easy corridor for sure, because here it doesn't look so deep, but in reality, it's quite deep. It never ends. So it's definitely something you need to be trained with in a lab, to do this dissection in a lab before doing it. And you need a good indication, obviously, to do it, because indications are very limited. Here, it was a dissection we did in the lab to see if we could put a clip on this segment of the ICA. So it's feasible through an FTOZ. There is no manipulation of seventh nerve. You keep the TMG intact, which is nice compared to fish and the approach from Shekar, but there is limited indication. Let's move to the horizontal segment of the Petrous ICA. This is the one we know the most, and which is probably the easiest segment to expose together with the clinoidal segment of the ICA. The exposure is a subtemporal approach. You can see it on this cartoon. This is a classical view of any description of the Kawase approach, with here by transparent through the temporal fossa floor, GSPN. You have here the internal auditory canal, you have geniculate ganglion, you have the labyrinth here, the cochlea, which is a little bit below GSPN and geniculate ganglion, and you have this ICA here below GSPN. So it's a subtemporal approach. This is drawing from Kentaro Watanabe. You peel the dura from the floor. You know all that. This is beautiful view from Dr. Rhoton here of the temporal fossa floor. Look at the bone, the shape of the bone. There is bump, there is proeminence. You don't recognize much here except the middle meningeal artery on GSPN, on the Petrous ridge on lateral aspect of V3. But if you drill, it's very rich below. You have here the labyrinth, you have internal auditory canal, you have geniculate ganglion, GSPN, you have the cochlea deeper, and you have this segment, horizontal segment of the ICA that run from posterior to anterior and then goes below Meckel's cave. So how to expose the ICA, only the ICA, the Petrous ICA? Well, you need to peel the dura from the temporal fossa floor. You need to cut foramen spinosum. You need to peel the dura from V3. Classic initial step of a Kawase approach. You incise the periostom along V3 and you peel the dura from V3. This is the principle of the peeling of the dura from V3, starting with sectioning the periostal layer. And then you have to go backward from back to front, peel the dura and find GSPN. It's important to recognize GSPN because the carotid is immediately below. So it's a great landmark to identify carotid. Obviously, GSPN is very thin. The carotid is very large. Sometimes carotid is more medial compared to GSPN. Sometimes it's more lateral compared to GSPN. So this varies according to one patient to another. One thing that is important is that there is an angulation between GSPN and carotid. It's not parallel. There is 5-10 degrees angle. So the more you go anteriorly, the more carotid get medial to GSPN. Sometimes it's not so easy to find GSPN, so the best way to find it is to have a facial nerve monitor. You stimulate those bundle of tissues that you see on the temporal fossa floor, which could be a remnant of periostal layer. Difficult to recognize. Well, you can stimulate and find GSPN. So once you have exposed the V3 GSPN, arcuate eminence foramen spinosum, you have exposed Glasscock triangle. Glasscock triangle was described in the 60s by Glasscock. He was an ENT. I think he was from Nashville. And he describes this triangle here, lateral aspect of V3, GSPN, spinosum. You have this triangle. If you drill here, you get to the lateral aspect of carotid artery, the part of carotid artery which is lateral to GSPN. I advise you to read this article here from James Liu with Fukushima, Almefti, Bill Caldwell, Sameshima all together. So here is the triangle that you drill to get to this horizontal segment of the Petrous ICA. This is exactly the view I showed you before. GSPN, you see this angulation between GSPN and ICA, and you see here the vertical segment of the Petrous ICA. Here they most likely have sectioned already the Eustachian tube, I believe, which was here. This is an article just to figure out the anatomy. A beautiful article from Professor Rhoton team. And you can see here the Petrous segment of the ICA. But you understand here, once we remove trigeminal nerve and Meckel's cave, that most of the horizontal segment of the Petrous ICA is in fact below Meckel's cave. So if you want to expose more of the Petrous ICA horizontal segment, you have to lift up Meckel's cave from the temporal fossa floor. And this is where the carotid canal is usually descent. So instead of drilling, you can also lift up the Meckel's cave and find the descent of the carotid canal, identify the carotid artery, and then you drill more posteriorly. Whenever you work on this temporal fossa floor, you need to be aware of the bone anatomy. And Paolo di Russo and Lorenzo, when they were working with me in Lariboisière, did this great article, which in fact means that you need to prepare yourself for variability before doing a case, especially in the Petrous bone. That's absolutely key because there is no single identical Petrous bone. What about the cavernous sinus segment of the ICA? Well, in my practice now, it's very rare to expose transcranially the cavernous segment of the ICA because the indication for me to go into the cavernous sinus with a transcranial approach are extremely limited. I have to say, when I have a cavernous sinus meningioma, I'm not taking the part of the meningioma inside the cavernous sinus because of the risk of oculomotor deficit. And whenever you take everything of this meningioma that is outside, in the vast majority of cases, the remnant of tumor inside the cavernous sinus grow very slowly, much slower than the initial growth rate. So you can follow the patient for a while and not doing radiation therapy. Still, there is sometimes indication for softer tumors like chordoma, like giant pituitary adenoma, chondrosarcoma, but it's not very often. I just show you some anatomy of this ICA inside the cavernous sinus. This is after section of all the cranial nerve because the carotid artery is deeper to the cranial nerve. What's nice in this picture is to see the turn. You have here lacerum segment, posterior ascending segment, posterior band, horizontal segment, anterior band, and you have the sixth nerve here. Oops, sorry. What I have done. Where I am. Yeah, sorry. You still hear me? Yes?
Yes.
Okay. So here are the segments of the ICA. This slide is nice because it shows you the correspondence between view from a transcranial perspective with a view from an endoscopic endonasal perspective. I think it's absolutely key to make this exercise of making the correspondence between the segment of the ICA transcranial endoscopic. It's not so easy. It's not so easy to look when you look at the ICA from an endoscopic perspective and you see this long segment of the paraclival ICA, and to understand that this segment, in fact, when you look at it transcranially, is very short, and it's just a posterior segment, ascending segment of the ICA. But depending on the perspective, it looks different, it looks longer. But doing this exercise, I advise you to do it. I go fast on those histological slices to show you the ICA into the cavernous sinus. This is coronal slices. And you see here the cranial nerve. This is third cranial nerve. This is sixth cranial nerve. And this is V1 here, V2 here, the bundle. Be aware that there is a lot of variation of the ICA inside the cavernous sinus in terms of trajectory. You have dolicho cavernous ICA, but the Petrous segment is quite constant. But once it's inside the cavernous sinus, it can do some significant bend. As you can see here, it's quite irrelevant when we go transcranial, but when we go endoscopic endonasal, like Carolina showed it, it's important to be aware of these variations of trajectory. The clinoidal segment of the ICA is the final segment of the cavernous sinus ICA, and this is a segment we have access to quite easily of the cavernous sinus ICA. And it's an important segment because whenever you have a pathology intradural that starts immediately at the level where the ICA exits from the skull base, if you want to have a proximal control, you can have it either at the clinoidal segment, at the Petrous segment, or in the neck. So you understand that the clinoidal segment is important. This is here the clinoidal segment of the ICA, which is limited by the distal dural ring. As Carolina said it, the distal dural ring is merged with the adventitia of the ICA. It's a significant anchor to the ICA. When you cut it to free the ICA, you have to be careful because you can quite easily cut the carotid artery. The proximal ring is just periostal layer of the bone with venous plexuses in between the ring and the adventitia of the artery. So it's not adherent. It's quite an irrelevant ring. It's a created ring when you drill all the bone around. What remained is a kind of ring. It looks like a ring, proximal ring, but it's not really a ring that anchors the carotid artery. So you see here the sagittal view of the ICA. Clinoidal segment is this small segment C5 here. Immediately after you have the ophthalmic artery going out into the optic canal. Important to be aware that the ophthalmic artery origin is either intradural, subdural, or extradural. This is a view of the clinoidal segment here, coronal view, and this is a view again, but a little bit more posterior. You have here the roof of the cavernous sinus, and you see the relationship here with the nerve, especially cranial nerve 3, which is in close contact with it. That's also beautiful views of the ICA. You see here the distal dural ring, which is really adherent to the adventitia. Here you see that between the proximal ring, which is here on the carotid, you have venous plexuses around it. To expose the clinoidal segment, you need to do a clinoidectomy. clinoidectomy, you need to be aware of the anatomy of the clinoid process. There is two routes, superior root, inferior root, superior wall of the carotid canal, of the optic canal, and the inferior root is the optic strat. This is a lateral view showing you what's behind once you remove the clinoid process. So you expose the optic canal, optic nerve, and internal carotid artery. Be aware that sometimes you have a connection between tip of the clinoid and middle clinoid process. That's a step to do a clinoidectomy, extradural clinoidectomy. You incise the orbitotemporal periostal fold, you peel the dura from the supraorbital fissure and from the cavernous sinus, you peel the temporal dura here, you expose the lateral aspect of the clinoid process. You see here the entry point of optic nerve into the optic canal. You drill the clinoid, it's an inside-out drilling, and you break the last thin shell of bone. You use pure diamond. You start with 4, you go with 3, and you finish the last bridges of bone here of the optic canal opening with a 2 millimeter if needed. You need a lot of irrigation. And at the end, if you drill below the optic canal, you first unroof completely the optic canal. Most often when we do a clinoidectomy, there is a need also for optic canal decompression. So we completely shave the optic canal, and below the optic canal, this is where we will find posterior to the optic strat, the carotid clinoidal segment. Here we have drilled the optic strat and we see the carotid artery, the clinoidal segment. Not so easy to expose completely the clinoidal segment to put a clip on it. So this is something you need to do if you really need it. I will skip this video of a clinoidectomy. This is a case for which I am interested with having this proximal control. It's a clinoidal meningioma. You can see that the carotid is inside, the carotid bifurcation is inside. So looking for the clinoidal segment of the ICA help me to find first the proximal aspect of the ICA, and secondly, if I have an issue, I can still put a clip dissecting the ICA from the tumor. For those tumors, I use a lateral orbital rim approach. It's an orbitopterional taking the lateral rim. I use the orbitotemporalis muscle corridor to avoid retraction of the frontal lobe. You can get to those tumors from below. It's like the endonasal corridor, except that it's more lateral. I skip this video also, or I go fast on it. Yeah, I skip it because we are already late. I will finish with cases of where we expose the most the carotid artery is when we do cavernous sinus exenteration. It's not so often, but it happens. The most frequent indication are those meningioma of the cavernous sinus that are aggressive, and most of them are aggressive because they are coming back, growing again after radiation therapy. And I have to say, I have done a significant number of those over the years. It's not so often again, but it happens. This is a case of a patient that has been radiated, I think, if I remember well, twice after a cavernous sinus meningioma. It became a grade 3. This patient had no infiltration of the PCom. She had a complete ptosis. So we decided that sacrificing vision here on this side was not an issue. Again, PCom was not infiltrated. We did a balloon test occlusion, and there was a significant delay at the venous face, but not so much. So we decided to occlude after the balloon test occlusion. We thought she would pass the balloon test occlusion, but this lady, whenever she was standing up, she had some tiny stroke. She had some speech issues. So she had to bed rest for at least 2 weeks. But it was still going on, so we had already occluded the carotid. So before doing the surgery for the cavernous sinus exenteration, I decided to do a bypass. But because she was previously operated 1 or 2 times, she had no STA anymore. So what I did, that's a tiny stroke after the occlusion. I did an occipital MCA bypass, which I have to say is very painful because preparing the occipital artery for such a long tract is difficult. The bypass went well. This is a video of the bypass. The biggest difficulty was to harvest the occipital artery. And here is a bypass, nothing special about it, except that it's a long tract. You need to put a lot of papaverine to avoid spasm. There is a significant risk of thrombosis. It didn't happen here, but it could have happened. But she had no carotid, so she was eager to get some additional flow. And this is probably why it didn't occlude. So after this surgery, we did the cavernous sinus exenteration. Cavernous sinus exenteration is not a happy surgery because you need to cut cranial nerve. But here, that was the only chance to control the disease. So here I'm on V3, peeling the lateral wall of the cavernous sinus. I am peeling here the dura from V2 also. I am peeling here the dura from the supraorbital fissure. We are just below the clinoid process. I'm cutting the orbitotemporal periostal fold. This is the lateral aspect of the clinoid process. And I am peeling completely the lateral wall of the cavernous sinus to get access to the nerve, to the anterior aspect of the tumor. It's a bit long as a video. Here, that's a nice part. I want to have a control of the ICA before the tumor. So I am just cutting GSPN here. I am exposing carotid artery. As you can see, the Petrous segment, I am drilling a little bit medial to the ICA. Why I drill medial instead of lateral? Because I wanted to keep here the Eustachian tube. If you drill lateral, you drill rapidly the tonsor tympani muscle, and you drill the Eustachian tube. I wanted to keep the Eustachian tube. So here I am exposing the carotid. I have this proximal control. You see the tumor here exposed. I will resect the dura at the end that I have peeled. I am drilling here the clinoid process. I expose the clinoidal segment of the ICA. It's a quite painful surgery because, again, you cut some nerve. Here I am going intradurally. I am looking for opening the sylvian fissure. This is optic nerve. I am looking for the carotid artery. You see this super extension of the tumor. You need to coagulate rapidly. You don't want to have malignant cells spreading into the subarachnoid space. So I coagulate a lot during this surgery. No risk for the cranial nerve because they will be sacrificed anyway. Here, that's the PCom. PCom is important. Whenever the PCom is sacrificed, it's much more dangerous. You definitely need a bypass. I mean, you cannot sacrifice PCom in most situations, especially if the carotid is already occluded. So PCom is a limitation. So here I expose PCom, and I want to put a distal clip. I cut here the supraorbital fissure. That's a painful part, all the cranial nerve, until I feel the bone of the sphenoid sinus. I am putting a clip here proximal to PCom. You don't want to put a clip too far from PCom because it didn't happen to me, but Bernard Georges told me this story that he put a clip at the clinoidal segment and there was thrombosis of this dead end segment, and the patient had some stroke because of embolism. Here I am taking now all the tumor out. The carotid artery has been coiled, so I remove all the cavernous sinus from the skull base. Here is at the deep part. I'm just controlling that PCom is working. I am cutting the third nerve. This is a painful part. You cut nerve. But again, this patient already had a complete ptosis. and ophthalmoplegia from previous surgery and tumor progression. I am putting here a clip on the Petrous ICA, and at the end, I take all the tumor out. You have to cut the tent, and you have to cut 5 behind. And this is the final view of this operation with the coil here. This is the final view of the brainstem. You want to avoid opening the sphenoid sinus if possible. This is a postoperative MRI. Luckily, this woman is still alive. I think I did it 4 or 5 years ago. Sometimes you do that for complex vascular lesion like giant aneurysm. You need a proximal control. This was a patient with this giant carotid distal carotido-ophthalmic aneurysm. He was getting blind. You see how it's pushing above the chiasma. He had a stroke on the contralateral retinal artery. So he was almost blind of the contralateral eye, probably because of embolic stroke, which make us in a difficult situation because the only functioning eye was the right one. He recovered after some vision on the left, but at the time I did the surgery, it was tough. I did a protective bypass in this case before starting dissecting the aneurysm. The goal was to trap the aneurysm and to reduce pressure. So we need to put a clip on the Petrous ICA. We had some issues with the Guedon artery because it was still feeding the aneurysm. But after surgery, the aneurysm shrinked and this patient completely recovered. I did a clinoidectomy here. I will show you the exposure of the clinoidal segment. Here I am exposing the clinoidal segment of the aneurysm. So here, yes, it was to put a clip initially, but in fact, it was already the aneurysm. So it was a big clinoidal segment, enlarged, and I could not put a clip and occlude completely. So here, I open the Sylvian fissure. I open also, I find the distal aspect of the aneurysm. As you can see here, this is the end of the aneurysm. I want to look at the perforators, to look at anterior choroidal artery and PCom, to put the clip just proximal to that. And here, which is nice, we did just an opening here of the falciform ligament, just to have more flexibility with the optic nerve. You can see how there is a print on the optic nerve. I did the bypass, and I will move here to exposing the Petrous segment of the ICA because I was unable to put the clip on the clinoidal segment. So I decided to go more proximal to the Petrous segment of the ICA. And here is a Petrous segment of the ICA, and that's where I put my proximal clip to trap the aneurysm. Here is a proximal clip. And then after that, confirming that the bypass was working, I went backward. You see here, this is PCom or anterior, I don't remember. No, anterior choroid, no, PCom. And I put the clip just distal to the aneurysm. I had few millimeters to do that. He went fine, it shrinked, and he recovered vision. I think I finished with balloon test occlusion. Just be aware that balloon test occlusion is important to know if you can sacrifice the ICA or not. We prefer to do a balloon test occlusion with occlusion because the balloon test occlusion itself is a risk of stroke for the patient. The delay we have is 1.5 delay of venous filing, and we always do clinical tests with hypotension 20 or 30 point below normal pressure. This is a case where the delay was almost 0, as you can see here. Whenever you go above 1.5 centimeter delay and you still do an occlusion, I did it once in a case where it was about 2 seconds, but I could not do a bypass. The situation was needed. Don't go on surgery too rapidly. Keep the patient bed rest for at least a few weeks. Keep the pressure high level, control if you have tiny stroke. If you have any of those, don't go on surgery. I did the surgery too early, and this patient had a significant stroke. It was an adenoid cystic carcinoma. I am done with the lecture. Thank you very much. Paolo? You're still there?
Yeah, I'm still alive.
You're still alive. Okay.
Okay, so thank you.
I think it was nice. We had a nice session. There is any question from the audience?
The chat, no, there is no question. So.
Okay. So I think we will try to prepare the program a little bit earlier for the next session. The next topic will be the vertebral artery or craniocervical junction.
Yes, maybe the vertebral artery and then the craniocervical junction next.
And we have the dates already for.
Maybe we have to ask to Imad because the 2nd February will be 8, but no one of you is available date. So maybe we will do the November 15 or
November 15 for the 1 of November, and the 2nd Friday for the December. Okay.
Okay. So
thank you, Paolo.
Thank you, Sebastian. Bye bye.
Bye bye. Bye bye.
Thank you, everybody.